All right, welcome. Hello. Hi, good afternoon. Welcome, everybody. I'm glad you made it here. It was an exciting day here in San Francisco. We planned for many things for this conference. We've never planned ahead for a tsunami warning, and I'm glad it was canceled. I hope everyone is safe and sound where you come from, and glad that we're all here to be together for this. I'm Carlin Center. I'm the Director of Primary Care Sports Medicine here at UCSF, and happy to welcome you to the course. These are all my co-chairs. We've spent the last year planning this course, and so each one will introduce themselves and we'll go from there.
Thanks, Carlin. And my name is Ellie LaRoque. I'm one of the sports medicine orthopedic surgeons with UCSF, and I work part-time out of the Orthopaedic Institute in Mission Bay in San Francisco, and then also part-time at the Redwood Shores Clinic. And thank you so much for coming.
Hello, everyone. My name is Gina Biviano. I'm a practicing athletic trainer. I have the blessing of managing our outreach program called Play Safe, where we provide athletic trainers to high schools in San Francisco. You'll hear more about that if you come to our Return to Play talk tomorrow.
All right, I'm Danny Keller. I'm one of the associate clinical professors in the physical therapy department at Mission Bay. I work at Cal Berkeley as well. And so I'll be walking around, I'm sure, talking to a few of the PTs in this department. So, Cam.
Thanks, Danny. All right, my name is Cam Liu. I'm one of the athletic trainers supporting the orthopedic surgery department at the Mission Bay Orthopaedic Institute.
Hi, I'm Katie Wallen. I'm also a practicing athletic trainer that works in the San Francisco office in Mission Bay, and I also have the pleasure of working with Dr. LaRoque at the Redwood Shores Clinic.
All right, so we're thrilled to be here. We're really excited about this year's course. This is the first time in many years that we've done an interprofessional course that brings together physicians, athletic trainers, and physical therapists. And we're excited to learn together and learn from each other. So thanks for being here. If I can have the first slide. Oh, yes. Oh, it was over there. The other slide said, please silence your phones. So thanks for doing that. And welcome to the course. Welcome to San Francisco if you're not from here. The other exciting thing about this year's course is we're using an app. And I think the app has helped us a lot to make this conference a little bit easier to navigate. And we hope that it allows us also to build some community. So please feel free to share on the app, like cool things that you've figured out about our location, or great food, or awesome coffee, or anything else that you'd like to share with folks. Hot tips, we appreciate that. This is our conference staff, so all of us are here to help. If you have questions, concerns, please reach out to us. Please grab us at any time. And we appreciate your feedback as well about the content of the course, about the app, about our communication. So we're always striving to make this course. Every year we hope to make it better than the year before, and we couldn't do that without your help.
Great, and then I just want to introduce some of the people that are going to be helping with teaching for the course. So we have some of our UCSF Sports Medicine physicians and physician assistants. They're shown here. You'll be meeting them over the next few days. And then we also have some experts from in and around the Orthopaedic Institute who are going to be helping with teaching for this course. Those are highlighted above. And then also our clinical fellows. So those are surgical orthopedics and primary care sports medicine fellows who are here for a year, the academic year, just doing some extra training with us, and they're going to be helping with some of the workshops. We have a few pediatric orthopedic and sports medicine specialists from UCSF who are going to be helping with the course. And we just wanted to highlight once again our athletic trainers. They're going to be helping with teaching, but also helping run the course throughout the weekend. We also have some physical therapy and rehabilitation specialists from UCSF who are going to be helping with the course, and also pain management, physiatry, rehabilitation, and non-operative spine physicians who will be helping with the course. And we have a few guest visiting clinical instructors who are going to be teaching as well. And these are our course objectives.
Awesome. So for today, we have a lineup of two really phenomenal speakers to kick off this course with two hot topics in sports medicine as far as knee exam and hip exam. We're going to have a break in the middle where there'll be some light refreshments outside, and please do mingle with the exhibitors. And they are all here supporting the course as well. And we're going to wrap up around 6:50 p.m. tonight. And so if you all have your name badge, you probably signed in. You only have to sign in once. That's how we're tracking attendance for this course. And then you don't need to do anything else for the next 2 days. For the speaker survey, you should have access to that in your housekeeping email. And then also there's QR codes kind of posted around. We do ask that because we have so much going on, it's a very lengthy survey. So if you're doing that in real time to keep it fresh in your memory, that's helpful. And then if you have any issues with that, please see Sari at the front. On the last day of the course, you'll receive an email to document your hours, finish up your evaluations, and then it will generate a certificate for you all to prove that you were here. And then pass it off to Danny.
All right, I get to talk about my specialty, parking options. So this is all you're getting from me this weekend. So first off, there's parking at the hotel. If you drove, you probably parked somewhere. So hopefully it's one of these options. If you parked on the street and you have a black BMW, it's being towed right now. But these are the rates for the hotel here. It's cheap. We can go to the next one. Hope you didn't park at the hotel. There's also parking available nearby at the Embarcadero Center. They have about 4 different parking garages, so pretty reasonable rates over there for the day. If you decided not to drive and you took Muni or the cable car or the BART or the ferry or you swam, this is where you can get from those locations over to the hotel. And then in terms of transition, so today everything will be in this room. Luckily, you guys don't have to go anywhere. But tomorrow we're going to have lots of different exhibits in different workshop rooms. So to get to those rooms, you're going to head 2 floors down below you. So you can get to the stairs and the escalators from either side of the room. You can go straight out through here, take a right, follow it all the way around. There's also restrooms out there if you're looking for them. If you want to get to the main lobby, you can also go out these doors here in the back, take a right, take another right. You'll see all the fancy elevators and stuff. And then when you get to the workshops tomorrow, you're going to go out all the way to the right, go down the escalator, and then take a right, go down the stairs, and then take another right, and you'll see all the rooms there. If you can't make it down the stairs, there's also an elevator when you go down the escalator directly behind the wall in front of you. So go around the wall, and you'll see the elevator.
And we know that was a lot, so if you don't remember all of that, again, we are all around to help you navigate this new space. So learning tips, I'm sure you have found the Wi-Fi and that it's not super great right now, but that is the password. If you're I found that on the hotel side, if you're in the lobby side, it's a little bit easier to access the Wi-Fi and it's working a little bit better over there. It's just once we pass these stairs, it's not working as well, but that is the password for Hyatt Wi-Fi. So if you are not staying at this hotel, you can enter that password a little bit lower and get on the Wi-Fi. Slides and handouts are available on the Whova app. You can see them under documents and handouts. And then there will be handouts available printed out for you for the in-person hands-on evaluations workshops. All talks that are just talks have a Q&A portion. We've let the speakers know that they should have about 10 minutes for Q&A, so you can ask your questions. If they don't end up having time or you have more questions, please feel free to add your questions to the Whova app, so that's how you can connect with us. And there will also be polls on the Whova app. We know that some of you can already access it, and some of you were very excited and answered all the questions already, which is totally fine. If you don't remember your answers, so sorry, you can't redo it. But your speakers will prompt you when to answer those poll questions, and then you can see the results live. Some of the handouts are organized differently, so you'll also see that when you attend your talks. And then for workshop timing, check-in will begin 10 minutes before the workshop starts. So that's just the end of the previous workshop time. So if you're in the main auditorium or you're doing something else, you can start heading to the workshop session about 10 minutes beforehand. Doors will close after the session starts, but of course there'll be a grace period, especially navigating day one tomorrow first thing in the morning, about 5 minutes. And then we also want to make sure that if you are on a wait list, you will get notified through the Whova app and through your email if you are removed from the wait list and registered onto the course. So you won't need to stand by at the door. The people checking you in at the door have no control over you getting on the wait list or not. So just know that you will get a notification from them. So we recommend that you either select a different workshop that is available or wait and enjoy one of the talks that are going to be in here. And next slide, please. Perfect. And then we will have a prize drawing on the last day in the afternoon. You have to be present to win. Two of the prizes will be course registration. We also have some UCSF headgear that you can choose from. And the different ways you can win are participating in the contest and surveys and polls online through the app. And we'll open a couple of these right after this course starts. We just wanted to wait for everyone to get here and have an equal chance there. Perfect. And then for meals and snacks, we are in San Francisco, so anything you want to eat is probably within a mile of you. We recommend, if you are eating out for lunch, we do recommend maybe ordering ahead just because, it's hard to time everything. But there are good offerings right above us from the hotel. So they have a market option and they have a cafe option where you can sit down. And then if you have a food recommendation, just drop it in the chat. And thank you so much, Danny, for mentioning the bathrooms. So there's a set on this floor right here. And again, if you go upstairs to the lobby, there's a set on your left as you go up the stairs.
So we would really like to thank our exhibitors. They have come to support this course, and it cannot happen without them. So please do your best to stop by just outside to chat with them. They have some great products they'd like to share. It'd be super great if you did that. And then we'd like to invite you to our courses for orthopedics. This is the PEDS course for next year. I don't believe a date has been set yet, but they are great. And then the next course will be, I believe, in July for the spine course, and that's on the next slide. So we definitely like to invite you to attend those courses. Some of the instructors will be the speakers for those courses, and they're so great. And then I would definitely like to invite you to possibly volunteer for an event that's very near and dear to my heart. That's the cardiac physicals that we put on for the student athletes of San Francisco that Gina so graciously runs. So we would always love to have primary care physicians or any type of provider that has experience in working with patients to help assist. So please, email us to volunteer. That is in May of this coming year, 2025. And then, of course, we have races that we do, Beta Breakers, Escape from Alcatraz, Triathlon, San Francisco Marathon, and Berkeley. And that's all through next year as well. Please sign up at the email listed below. And then, of course, there's ways to connect with us always with social media. All our social media links are listed there. So please come follow us.
All right, so we are, again, so happy to welcome you here. I want to thank the course chairs for all the hard work you've done, and I'll go ahead and introduce our first speaker. So it's my pleasure to introduce Dr. Sara Edwards. This one on? Okay. Dr. Edwards is a UCSF professor and orthopedic surgeon specializing in caring for patients with shoulder, elbow, and knee injuries. Dr. Edwards is the director of the new UCSF Women's Sports Medicine Center, which is the first sports medicine program in the Bay Area to focus exclusively on female athletes. She is also currently a team physician for City College of San Francisco, University of San Francisco, and the Oakland Ballet. Her research interests include patient outcomes after shoulder arthroplasty and labral repair, biomechanical evaluation of shoulder arthroscopy procedures, and preventing injuries in young athletes. Dr. Edwards is going to teach us all about the knee. Please join me in welcoming Dr. Edwards.
Thank you. Thank you, Carlin. All right, and I've been told I can't stand there. I need to be over here by the slides, so sorry. So it's kind of like a TED Talk. Oh, hang on, maybe I'm too close to that. I'm way over here. Can you guys hear me okay? Everyone good? All right, thank you all for coming today. It's been a very exciting day, like Carlin said, and I was operating when the Nixle alerts went off, and that's not a good place you want to be. Everyone evacuate, get out, and we'll have a patient open on the table. So we finished our surgery and got done calmly, and by the time we were done, the alert was off, so that was a good thing. Both of my children were frantically calling me, though, to check in, which wasn't good. They're like, "Where's our mom? What are we going to do?" Anyway, so welcome and thank you. I'm curious, and this is a great crowd that we have here. How many of you are primary care MDs? Let's see hands. Great. Primary care providers, NPs and PAs. Amazing. All right, physical therapists. I see my two here. And then we got a crowd back there. Great. And athletic trainers in the room. Great. Okay, what am I missing? Who am I missing? Anything? Yes, sir. Oh, wonderful. Thank you for being here. All right, thank you. All right, so thanks everyone for coming. It's great to have a nice mixed crowd, and hopefully everyone can mingle and meet each other. And, again, we have lots of great PTs here. Go on? No, we're good. Anyway, so I'm going to talk to you a little bit about the top 5 things in primary care for the knees. And I'm going to start with my least favorite, okay? So I think this is almost everyone's least favorite. It's kind of like the low back pain of sports medicine, which is patellofemoral pain. So anyone here had patellofemoral pain in their life? Yes, a lot of us, right? So I've had it too. It was probably my first intro to orthopedics. I was a 15-year-old girl being taken, to see, I had to do PT and see a doctor. And after like a year, he finally gave me an MRI. It was totally normal, of course, and it was all patellofemoral. But it hurts. So if you've had it before, what's hard for patients, I think, is that it's minimized a bit because we don't operate on it usually. But it is painful, and thank God we have great PTs that can help take care of it and get people balanced so they feel good. But it is, I think, having had it myself, it was pretty debilitating. I remember having to miss a season of sports because it kept flaring up and was painful. So we're going to talk a little bit about it. So what is patellofemoral pain? There's no continued consensus on what the definition is. Most of the studies out there are really level 5 evidence, not great. The hallmark is anterior knee pain. So it's kind of all lumped into one thing. Oh, it's patellofemoral pain, this anterior knee pain. It's also known as runner's knee. So a lot of runners come up with it. We know that it affects women more than men. And there's a lot of theories about that, about our Q angles, our hips being wider, us being a little more hyperlax. So those are reasons that we might get it more than our male colleagues. The pain is classic for anterior knee pain, usually with prolonged sitting, with jumping, squatting, running. They feel it going up and down stairs, up and down hills. A lot of patients will say it hurts more when I walk down the hill than when I walk up. So those are kind of the classic things you hear. It's also, sorry, he's calling me over. There's something called the theater sign. See, I can't get too close to that though. I can't, yeah. Oh, you want me on that side? Okay, all right, walking over, sorry. So there's the theater sign as well, which is when, again, patients sitting in a theater for a prolonged period of time will feel it, or if they're on an airplane, that's a common thing. Sometimes driving a car, they feel it. So what is the etiology exactly? We know that there's usually some type of muscle imbalance. So, we talk about quad deficit or quad weakness, but sometimes the patients are really strong, and you'll see that outer quad is overdeveloped in relation to the inner. So there's a lot of focus on strengthening the VMO, or the vastus medialis, on the inside, and kind of stretching out the outer part, and the IT band can be tight, which can pull the patella laterally. They can have poor biomechanics. So again, a lot of women, unfortunately, we have a more valgus alignment to our knees, and we also have wider hips than male patients. So that puts our knee at a biomechanical disadvantage for multiple things, also ACL tears. But with patellofemoral pain, it's also linked. That valgus alignment will tend to drive the patella laterally. That's what biomechanically wants to happen. And so we have to combat that by different reasons. Other reasons you can have it can be patellar tendinopathy. They can get fat pad impingement. It can be plica syndrome. We're going to touch on a little bit of these. Again, runners, it could just be overuse. They can have poor mechanics when they're running. They can have patellofemoral cartilage pathology. So once in a blue moon, if a patient's really done a lot of PT and they're not resolving, you try everything. You try NSAIDs, injections, bracing, all these things. If after a year they're not getting better, sometimes I'll recommend actually to scope their knee and just look inside. And sure enough, 90% of the time I'll find a big patellar flap or something that did not show up on their MRI. There'll be a flap of cartilage that's delaminated, and you cut that out and they feel so much better. Again, patellofemoral maltracking, that's kind of the hallmark where the kneecap wants to go laterally. And also they can have gross instability where the patella is just frankly dislocating. That's usually a little more, they'll tell you like, oh, my kneecap dislocated, it's a big deal. So there's different kind of gradients of pathology. Sometimes you get a patient that's really strong and fit and you'll see it. Other times it's kind of a hyperlax female. But we do all call it the same thing. I'm not sure if that's working. There we go. Again, the key, it's most often somewhat multifactorial. Patients with different etiologies of patellofemoral pain may present with similar symptoms. And again, figure out what the problem is to guide their treatment. And again, the one thing I tell my patients, I'm like, you can't just go to PT for 6 weeks and think it's going to go away. I'm like, you need to go and focus on the exercises, learning what to do. And then I tell them it's like brushing their teeth. You have to keep it up. You have to keep going because otherwise it comes right back. So it does need to be usually some lifestyle modification where they incorporate the exercises they learn into their routine. So again, these are some of the muscle imbalance. You can see this dynamic valgus where when they land, they're kind of collapsing into a valgus position. Valgus meaning your hips are aligned, your knee is here, and then the foot or ankle is external or out compared to the knee. They can have weak abductors, weak core, or weak quads. So usually, the therapists are going to focus on strengthening all of those parts. Again, treatment is PT, PT, PT. Chronic is more common than acute. Often, this patellar tendonitis, so often they'll get chronic tendonitis there. They can have pain at their inferior patellar pole, often greater in extension, and it's less when they start flexing their knee. So these are the differential you have to kind of figure out. For fat pad impingement, I think this is one of the harder ones because you see this a lot. I see this more in my male patients. Sometimes you'll get an MRI and you'll see this very hypertrophic fat pad. You can see this fat pad is larger than usual, pushing back. The radiologist often won't call it, and it's hard for us to diagnose it. It can occur from chronic maltracking. I've seen it in football athletes from kickers. So if you think of a kicker as going into hyperextension all the time, they can develop fat pad impingement from repetitive kicking that they're doing for years at a time. You can get that post-injury or post-surgery. So sometimes the fat pad will hypertrophy in relation to us doing a knee arthroscopy. They can get hypertrophy of that fat pad and then it can start to impinge, particularly after an ACL. That's when we tend to see that. Sometimes that needs to be arthroscopically debrided. I often will try an injection first if I suspect it, but then arthroscopic debridement, and you just go and take out that impinging fat pad and they feel significantly better. And then plica. So have you guys heard the term plica syndrome before? A lot of people, they've never heard of it. And then, often when I'm in the OR with like a fresh medical student or something, they're like, I've never seen that before. And we don't often see it. It's rarely picked up on the MRI. But a plica is a remnant of an amniotic band when they were in utero. So during development, all fetuses have these plica bands or these remnants, and then they should dissolve over time. But sometimes they don't. So you see these thickened bands of tissue like this, that's scar tissue that kind of runs through there. And when we get into a knee and we see that, it's very exciting because you just cut it out. It's a 5-minute procedure, and they're so happy. They'll tell you, oh, my plica went away. That's good. And the patients are always like, what's a plica? You know, they don't know, but when I see it and I excise it, I know that they're going to have a good outcome for the most part. So that's always fun to find one when you're doing a diagnostic scope. Again, with a plica, usually sometimes a sharp radiologist will pick it up. They'll often do PT injections. You can do an arthroscopic debridement, and then it helps their patellar mobility as well. The plica band can actually abrade the cartilage in the knee, so that band is very thick and a big scar piece. With runners in particular, you'll see patellofemoral pain when they're usually in a period of accelerated training. So often these people that start training for a marathon, they start really rapidly increasing their activity. We'll start to see this symptom. They can have poor running mechanics, and it can be footwear. So they talk about, one thing I look at when I see a patient with anterior knee pain is what's their position of their foot. So patellofemoral pain is associated with a flat pronated foot, and that's where they talk about a stability shoe, where you want to actually increase their arch, and their support can help actually their knee pain. All right, so that's one thing to suggest to them, is they can get checked for their foot position. The one way I check for that in the office is I'll have them stand there and just without shoes on and see if their foot collapses when they're standing. And when they go up on their toes, if they recreate their arch, that's a sign that they have flexible flat foot deformity that can increase the valgus stress on their knee and cause patellofemoral pain. So sometimes a simple orthotic or getting a better shoe is all they need. Also getting cushioned shoes. So sometimes they'll wear their shoes too long and wear out. So I tell patients, if you start to see wear on the bottom of your shoes, it's time to change them. So often frequent runners don't realize they need to switch them usually every 2 to 3 months. It's pretty frequent. So again, what to do about patellofemoral pain? Again, try to identify the etiology if you can. Figure out what's going on. Again, PT is great. You know, we talk about taping. I think taping really works. PTs out here tape. Who likes to tape the knees? Yeah, you do. So I think that can help at least give temporary relief so you can get them to rehab if their pain is too severe. And you see a lot of trainers doing that on the sideline as well for athletes. Again, most of the time, conservative treatment is all they need with PT. And again, you know, take-home points, again, multifactorial, what's causing it, try to figure it out. And again, there's no consensus or true definition. So take care of your knee. All right, and then knee arthritis is probably the second most common thing I see. And I think it's getting more common in a younger population because we have all these young athletes now that are starting to turn 30 and 40 that have had ACL ruptures when they're 15. So from the youth sports craze of America. So we're starting to see this younger and younger, but usually it's going to be an older patient over the age of 45 or 50. That's my age, so I don't think I'm old yet. But so when I say older, I'm not saying I'm too old. But that's when you start to see typically most arthritis. And the main etiology of arthritis is really the loss of the native cartilage in the knee with age, trauma, and also potentially an autoimmune disorder, so rheumatologic disease where their body's attacking the cartilage. And you know, the hallmark on x-rays, you see this narrow joint space right here. So you see the loss of the space. You can see on the left set of films, the right knee looks good. The left one, again, narrowed. So that's how we diagnose that when they're in the office. Their hallmarks, they'll complain of pain, swelling, stiffness are the primary symptoms. It can make it difficult to do their activity of daily living as they get older. They'll start to decrease their walking stamina. I can't walk 2 blocks now, doc. You know, they'll complain of a grinding sensation in their knee. That's really common. They often will be stiff first thing in the morning, and they'll say, oh, when I stand up or get out of bed, it's really stiff. And then once I get going, it feels better. So they kind of will lubricate their joint, get moving, and they feel better. Pain can cause a sense of weakness or buckling. So that's interesting. Some of them will feel their knee give out, and it's because they're disinhibited due to the pain. and their muscle will give out right away. And again, they can also get locking or a sense of stickiness in the knee. It can, again, make the noise. That's the most common thing. How many patients complain of noise in their knee? I'm always like, is it painful noise or just noise? Because it's common in young patients too. It's common with patellofemoral pain. But they'll often, almost every arthritic patient will talk about the noise they hear or the grinding that they feel. You know, we unfortunately don't have a cure for arthritis yet, but there are lots of treatments, and it all starts generally in their primary care office. You know, NSAIDs, I'm a big believer in just eating NSAIDs when you need to, as long as their stomach and kidneys can take it. I like injections as well, so I think injections of cortisone can really help. You obviously don't want to give too many too frequently because you can damage the joint, but it has been shown to be safe. Every 3 to 4 months is safe, and it can really buy patients time. So I'm a fan. I think we have a workshop tomorrow on how to give a cortisone shot, so I think that's a great thing to be able to do and offer patients. Some of the newer things on the market, you know, PRP is really popular. It's gained popularity. There's some compelling studies. So when PRP came out, so PRP is platelet-rich plasma, for those of you who have not heard of it, but it's a procedure that's done in the office where blood is drawn from the patient. It's spun down, and the platelets are isolated. And inside those platelets are all these growth factors that help stimulate downregulation of pain factors. So you're not making cartilage regrow, you're not making it come back, you're not curing arthritis, but it does have an anti-inflammatory effect. So that's how it works. There's a range of pricing for PRP. So, you know, it's funny, some people are charging $50,000 for a PRP shot in San Francisco, which I wish I was that guy. Most of the time, I think it's much more reasonable. And insurers are starting to catch on that there are some good studies that show efficacy now. So, and UCSF just did a great study that was published in Arthroscopy, my partners Zhang and Feely, about PRP and some of the positive changes they're seeing on functional MRI on the cartilage. So there is some good to it. And most of the time, clinical efficacy is about 85% of patients will say they had a decent result. So something to think about. Still usually not covered by insurance. Workers' comp will cover it sometimes, but not insurance. And then PT for arthritis too. I like to send patients for PT. I think if they can get stronger. Other things is just, I think, talking to them about weight management. A lot of patients are overweight. Now you guys can prescribe these wonderful GLP-1 drugs that can help a lot of patients who normally maybe couldn't, take those in the past to lose some weight. The knee sees about 4 times your body weight. So every pound that you lose, I tell patients, you lose 5 pounds, it's 20 pounds to the knee. And that's impactful because they all can probably lose 5 pounds. You know, you tell them you need to lose 60 pounds, it seems overwhelming to them. But even small incremental changes can help them. So I encourage that in a kind way because people get sensitive about their weight. Other things, lifestyle modification. This is one thing I've seen in my tenure as a doctor. I mean, when I was training, they would really tell people, you should never run again and change don't exercise, you're going to aggravate your knee. That's completely changed. So now we encourage people to exercise. We know that lubrication is good. They might modify what exercise they're doing. I don't recommend people go out and start training for a marathon, but they should definitely cycle, cross-train, do things that feel good to their body. Again, good for their mind, good for their weight management, good for their joint to keep moving it. Patients with knee arthritis that exercise sense less pain, and we don't fully understand why, but they do, and they're able to go longer than patients who don't. Let's see, physical therapy, obviously increasing the range of motion and flexibility, strengthening the muscles in your core, your glutes, your leg are all gonna help you and even down the road when they do end up having surgery. And then bracing and wearing a knee sleeve. Again, I think mainly for patients that are having repeat effusions due to arthritis, that can help. So putting on like a simple knee brace. I don't try to get too fancy with them, although sometimes I do an unloader brace. So unloader braces are nice because they'll push the knee into a more valgus position or a more varus position, depending on where most of the arthritis is. So you have a patient with isolated medial compartment arthritis, you can push them over, and it does help. So that's a fancy brace. Oftentimes I'll just do a knee sleeve to start because they're cheap and easy. So again, non-operative treatment's your mainstay for starting with patients. Again, NSAIDs, Avoid opioids. You get a patient hooked on opioids, their pain will escalate over time, as we all know. The cortisone injections, hyaluronic acid injections like Durolane or Synvisc, those are effective as well. And that's better in mild to moderate arthritis. They don't work as well in end stage, but they're good choices. And then again, now there's some interest in the platelet-rich plasma, and there is some efficacy to that. As far as operative treatment, so in someone with really mild to moderate arthritis, occasionally I will scope that knee if they've got something mechanical happening in there. So if there's loose bodies floating around, if there's a flap of cartilage, if the arthritis isn't severe yet, I do think they can benefit from a scope. The research shows anywhere from 5 to 7 years of pain relief, just a knee scope in someone with mild arthritis, not for end stage. If it's isolated arthritic lesions or isolated osteochondral lesions, then we talk about some type of cartilage restoration procedure. You can realign the knee. So let's say they just had it on the inside of their knee. You can do an HTO and realign the knees so they're not putting that pressure on the arthritic area. So that's one thing that we can do in a younger patient with arthritis that still wants to have time and run and be more active. These osteotomies, you can do partial knee replacements. So if they just have arthritis in one compartment, so you can just replace that compartment. That's an x-ray of that on the far left or far right over there. And then obviously total knee replacement is the end game. So I think I'm always grateful that we have these options to treat people, because total knee, before that existed, patients would just be crippled. Now they can have the procedure and usually, be functional and get back to their activities. Okay, so ligament sprains. Let me check my time. Okay, I gotta go faster. All right, ligament sprains. So these are the fun ones for me as a sports surgeon. So I really like, taking care of ACL tears, MCLs. There's the lateral collateral ligament, PCL. Then there's the lesser known cousins, the posterolateral corner in the back. And then obviously then you can have a full knee dislocation where you rupture multiple ligaments at once. And that's one of our, this is classic. You can see his name, boom, right? Okay, there you go. So he's, those are always, as a surgeon, and probably most of you as doctors, when you watch football games, I'm always looking at the injured, what's going on. Who else does that? Am I the only one? A lot of us, okay, yeah. And particularly if you're taking care of teams, you're like, what? You know the teams out there. It's funny, right now, my former residents, I used to be a physician at Northwestern, and one's the Lions team doctor, and the other was the Texans team doctor, and they were out there, taking care of the teams together at the game. It was fun. I felt like a proud mom, like watching my students out there. So ligament sprains can be contact or non-contact. The athletes will often describe a twist or torque on the knee. They'll hear a pop followed by swelling in the knee. Sometimes they're unable to bear weight. Very classic findings though. This is usually an acute injury that happens while they're in the field or playing, where they hear this pop and feel it. They know something's wrong, usually right away. I just saw one of the worst knee dislocations this year I've ever seen, where a woman was teaching her daughter how to drive, 15, and she ran her over and she completely dislocated her knee and ruptured her artery. So that was an interesting one. She had every ligament was out and had to build her knee back. Anyway, so the treatment depends on which ligament is torn. Usually MCL or LCLs, these are extra-articular, meaning they're not running inside the joint. They're on the outside of the joint, and they have good blood flow. So they tend to heal well on their own with bracing and PT. All right, so those are the good ones for patients when you see that. ACLs and PCLs, which are intra-articular, are the ones that we often have to operate on, and not PCLs so much. Usually we can rehab those, but the ACL, in a younger, active, healthy patient who wants to get back to sports, those are the ones that we do. And that's one of the most common surgeries that we do here in our sports department. You can tell it's complicated. There's a lot of flow charts here, so I'm not going to go through them all. But, there can be partial ACL tears. Sometimes you might wonder, why are they operating on that one and not that one? So again, a lot of it's age. A lot of it is is the ligament completely torn or not? How functional is the patient? What are their goals at getting back to? And that's kind of how we treat that. them. Again, ACL is one of the most common things. PCL in the back of the knee is relatively uncommon. When we do see it, we often will send them to rehab first. And then that's what Christian McCaffrey just had, for all you San Francisco 49ers fans. So I felt bad for him. He just came back from his Achilles and had that. But I don't know if he's having surgery or not, but we'll see. He's not, right? He's rehabbing, yeah. I actually had one of my city quarterback had one of those this year, and he was back in 2 weeks, back to playing. So it must be the PT that was helping him at City College. Again, and then switching gears, some meniscal tears. I mean, we can ask more questions about ACLs as we go on. This is really the most common surgery for orthopedic surgeons in general is doing a meniscus debridement. All right, so it's the number one code that's done. And it's a tear in that C-shaped cartilage in between the knee, in between the bones of the knee. So these two cartilage discs sit in between and act as shock absorbers. They also give us some stability for translation as well. And they frequently tear. They tear as we age, and they tear sometimes with trauma. Most of the time it's age-related degeneration. So people think of it as a sports injury, which it can be, but I'd say 90% of the time I see it, it's in a 30 to 40-year-old that's doing nothing. They don't understand, well, what happened? How did my meniscus tear? And they just got up in a funny position, or their legs were crossed and stood up. And sometimes their meniscus can tear from that subtle of a movement. Their hallmark, pain, swelling, stiffness are the hallmarks. They can have trouble bending or straightening the knee. It's a big tear if their knee gets locked. So their knee often can get stuck and they can't extend it all the way. They'll be kind of come in to see you, and they'll usually be on crutches because they've gone to an urgent care somewhere, and their knee will be stuck in that position. They can often have a crunching or clicking motion or feeling when they're moving the knee. So that's kind of classic. It's usually caused by twisting or rotation of the knee with weight. Again, can be from a sport or just from activities of daily living. Definitely related to knee arthritis. So you might wonder, well, why are they treating this one with surgery and this one not? The more arthritic knees often can respond very well just to physical therapy and injections. So, and that's something that's evolved as well since I've been practicing. We used to operate on everybody with a meniscus tear, and now we're much more conservative, and we'll send people to rehab and give them time because often they will feel better with PT, particularly the older patients. Sometimes not. Sometimes they'll still have pain and swelling, and then you go in and do a debridement, 3 or 6 months down the line. But we tried the conservative management first. In the younger, more active patient, we want to get to those menisci quicker. We want to fix them if we can. So again, treatments can be rest, ice compression, elevation, NSAIDs, and PT. And again, treatment also depends on the size and location of the tear. The other thing I've seen is much more of a push to fix these. So we used to really debride, I'd say maybe 85, 90% of them, and maybe fix 5, 10%. The repairs have become easier, and the research is clear. If we can repair a younger patient, it's better for their knee longevity long term. So I don't know who else follows pro football, but there was a big lawsuit with the Eagles player like a year ago. It was the largest lawsuit ever to an orthopedic doctor who's a very well-respected surgeon in the orthopedic world. He's famous. He's been the Pittsburgh Steelers doctor for years, and he was sued and lost, as well as the place where he was doing physical therapy was sued and lost because they did a meniscal debridement and not a repair on him. So just something to think about. It was interesting because they thought they were doing the right thing. I felt like it was a erroneous lawsuit for sure, because it was, but there is a push to fix them more. I don't think they should have had that outcome, but I'm just a sports surgeon. Other common things. Last one, so tendonitis. So this is super common. And in the knee, we have multiple tendons. So we've got the quad tendon, the patellar tendon. You can get hamstring tendonitis in the back of your knee. And then you can get bursitis of the pes. So I'm going to show on the physical exam kind of where I palpate. Tendonitis essentially is a word for inflammation of the tendons due to overuse. Patellar tendonitis, more common in people under 40. Quad tendonitis tendinosis or tendonitis is people over the age of 40. Under 40, they call it jumper's knee. It's really common in basketball athletes, also in runners, okay? Quad tendonitis, again, I see it in my 45-year-old weekend warriors who are still playing pickup basketball. They'll get more quad issues. The problem with tendonitis and those things is that they can lead to ruptures down the road. So we want to catch them and get them treated and give them an adequate period of rest so they don't rupture the tendon, because that's a big deal. They need surgery and they are off for months. Usually it's like a 6 to 9 month recovery for that. Again, main form of treatment when they have tendonitis: rest, ice, medication, NSAIDs, and knee support with either a band, like that's a nice one for patellar tendonitis, and PT. Prevention is key. Good warm up before their physical activity. They want to stretch prior to sports. If you experience pain, don't push through it when that's really painful. You want to strengthen the thigh muscles, focus on good technique. And thank you so much for your attention. I'm going to do the knee exam next. I'm only here today because I'm taking my daughter to see Taylor Swift tomorrow. So just saying, so I'm here. So anyway, thank you. Headed to Vancouver. Anyway, it's funny I was told them when we were planning the conference months ago, they're like, does anyone have a conflict on this date? And I'm like, I do. And everyone's like, what are you doing? I'm like, I'm going to Taylor Swift. I've had these tickets for over a year. We're going to Taylor Swift. Anyway, all right, so this is Gina. She's gonna be my model. All right, and we're gonna talk about knee exam. So main thing I do when I see a patient in clinic is I just look at them first, right? I watch them walk in the room. I want to see how they're walking. Are they limping? Do they have an ontologic gait? Obviously if they're coming on crutches, you can see if they have an effusion in their knee. You can get a lot just by watching someone take a few steps, Great. You can see if they have hyperextension in their knee. And then I also will just look, here, I'll come over here so we're on the camera, right? So here, if you face me, turn around. Yeah, there you go. And, I'm looking to see, does she have any varus or valgus? Gina's got, good alignment, maybe a little bit of varus, just a touch. So when you look at her legs, so again, varus being a little in like this and valgus being out like this, okay? And then once I see it, I'll have her sit right here. And you can look for an effusion. So I think effusion is really important. When they have swelling in the knee, something's wrong inside there, all right? That means, we don't know what, but that means usually something's wrong with the cartilage. A ligament is torn in the knee or the meniscus is torn. There's a loose piece floating around, but something is wrong. That's kind of one of my indications for ordering an MRI when I see someone who's really swollen. Unless they have arthritis, we'll get the x-ray. Do you have arthritis? You don't need an MRI. But if the knee x-ray looks clean, then that's someone, if they've got a big effusion, then I'm worried about something's going on. So I would kind of, my hands are freezing, sorry. Kind of palpate. And I like to check for an effusion by kind of milking above the knee. So this is their suprapatellar pouch. And I'll squeeze that area and compare. So you can look at both knees, kind of take your hand, squeeze it above, squeeze both sides of the joint. And you can see if someone's got swelling, you'll feel it. You'll feel this kind of spongy feeling. You can feel the fluid if one side's off. I'm gonna have you lie down. And then I'll just do things like, usually I'll have them do a straight leg test like this. All right, so I'm testing the integrity of their extensor mechanism here. So I'm looking at their quad tendon and patellar tendon, and I know she's firing fine. If someone can't do that, usually there's a rupture or problem in that quad or patellar tendon, and you'll get a lag. It'll be saggy like this. And often, if they can't do it at all, usually there's an acute rupture, but they'll kind of sit like this, and you'll say, okay. And then if you lift it for them, and you'll see it drop down, then you know either the quad tendon or patellar tendon is ruptured. So again, feel for the effusion. You can kind of translate the patella back and forth like this. So I'll feel the kneecap and push both medial and lateral to see how much translation they have. If they're hypermobile, they'll often slide all the way over, and we kind of grade it by quadrants. 1 to 4, and how far you can push them over laterally. And then I will also kind of palpate on the patella and see if that's painful there, all right? You can do that with their legs straight too. You push straight down on it, and if they have that patellofemoral pain, they go, oh yeah, that's where it hurts. That's where I feel it, okay? I'll take her through a range of motion, make sure she's okay, that feels all right. And then I'll often put the knee in a little bit of flexion like this. And then I'll palpate the different tendons. So I'm palpating her patellar tendon here. They'll often, if they have tendonitis, we'll feel it right at the bottom where the patella and the patellar tendon meet. And then I'll palpate the quad tendon up here. If they're ruptured, you can often feel a defect. Your thumb will kind of fall into the defect. So I'm feeling her quad tendon. Then I like to palpate the pes. So the pes, the goose's foot, pes anserinus. So it's where the hamstrings come down and they insert right here, right above the MCL, and there's a bursa there. So bursas are these fluid-filled sacs that when they're inflamed can fill with fluid and become painful. There's a lot of nerve fibers in the bursa. So I'll palpate along her pes bursa right there and see if that's painful. You feel good? Okay. And then the joint line. So the joint line, the best way to find it is to put your thumb on the bottom of her patella, and you can slide it right off the edge. And you feel the patellar tendon. It'll slide right into a soft spot right there. And then you just kind of march your thumb around the side of the knee. So I'm on her medial joint line right here, and you're looking for pain. And so does that hurt you? No? Okay. But if they have a meniscus tear, that often will be painful. So that's another way, if someone's had chronic knee pain and it's not getting better, I'll palpate their joint line because I'm looking for that meniscus tear. All right. And then other things I'll do, you want to check for stability. So I'll check a Lockman test. So this is an ACL test. So you have them completely relax their leg. And then I wrap my hand like a C around her tibia. And then my other hand, a C around her femur. And then I pull anterior translation. And I'm feeling forgive. If that's positive, that's the most sensitive test for the ACL, okay? And the other one is the anterior drawer test. So Lockman is about 30 degrees of flexion, and then anterior drawer is at 90 degrees. So same thing. And with that one, because their foot is stable on the table, then I often will put my hand just behind here and kind of feel as I pull forward. And you can feel if the tibia translates in relation to the femur. It took me a long time to feel good about that test, but once you do it in everyone over and over and over again, now I just feel it, like, oh yeah, it's gone. But it probably took me till I was a 5th year resident to really feel comfortable and being like, oh yeah, it's out. It takes a long time and examining a lot of knees. The posterior drawer test, same thing, knees at 90 degrees, and I'm gonna push straight back, and that's for a PCL tear, all right? The other ones are for varus or valgus stress. So I'm testing our MCL here. The MCL is the ligament on the medial side, and you want to bend the knee to about 30 degrees, and you give a valgus force. So I'm just pushing, and the patient will say, oh, that hurts, I feel it. Or they might say, or you could feel it actually open. So grade 1 sprain, they'll often just feel pain. But if it's a 2 or 3, like a more involved sprain, then you can actually feel the knee open up. And then varus stress right here, same thing. I'm pushing the other way, pushing into varus by supporting her leg and pushing her forward. And then McMurray's test is a good one for meniscus. So I bend the knee to 90, and then I'll rotate her leg like this. This is for meniscus tears, okay? So go like this. And that's how I test. And sometimes I can move the knee too while I'm doing that. Kind of go like this. That bother you? And I'll flip it around. And if it's positive, they'll go, oh yeah, that hurts. So did I get all my knee exams? Did I miss any? Is there any that anyone else wants to see? That's a basic one. Yes?
You do the pivot shift.
The pivot shift, yes. She's like, please don't. It's not super comfortable on an awake patient. That's why she's like, oh God, I will demonstrate it gently. So I do the pivot shift. So pivot shift is for ACL. And I like to tuck the ankle into my elbow. So my ankle's here, and then I push a valgus force here, and then you bring the knee from extension into flexion like this. And if it's positive, so when you go into this, you're internally rotating, putting the valgus force on, full extension. And if your ACL is insufficient, that will sublux your tibia in that position, just being like that. And as you go into flexion, you'll see or hear an audible clunk as the tibia reduces in relation to the femur. So that's what a pivot shift is. But usually we only do that on patients that are asleep. So it's hard to do it in the clinic, okay? Okay. Yeah.
What does that suggest?
ACL's out. It's ACL insufficiency.
Fully out? Or?
Fully out. Yeah. That's actually the best test for it is the pivot shift. So that's how we know definitively like it's not working. So.
It's hard to relax as a patient, though.
It's really hard. Yeah. When they're awake, their quads will fire and we won't get it. Yes.
Do you ever do the Thessaly?
I do sometimes. You want to do it? Okay, so we stand up for that one. So the Thessaly test is a patient will stand, flex to about 20 degrees, and then you rotate, like that, right or left. And that's indicative of a meniscus tear. They have pain. Yes?
What do you do when you got looking exam findings, like a abnormal Thessaly and a normal Murray or the other way around?
Yeah, I count one positive test as being positive, so I'm still concerned. Yeah, I am like, okay, their Thessaly's positive. Even if the McMurray's negative, then I'm concerned. Or even if they have joint line tenderness, that's in the swelling and effusion, then I'm worried, hey, they might have a meniscus tear there. Yeah. Yes?
Any modifications for very large or more difficult?
Oh, great question. Yeah, it's hard. You want to lay down again? And for me, again, commonly that's with like football. So I, sometimes I put my leg up here. If my hand can't get around their thigh, okay? So my leg is up here supporting her, and then I'll push down. So my thigh is acting as that C, and then pull like that. So that for me has been helpful. I also think for I'm going to show to test the MCL, I'll bring the leg kind of off scoot over the edge. There, I'll kind of dangle the leg off the table and just flex it to 30 degrees. And then I push that valgus force, and then you don't have to hold it. So it's easier on your body. It's an easier exam. She's stable on the table, the patient's stable, and you're just pushing that way. Okay, so that's a nice way to do it. And then for varus, you can kind of cross their leg even like that. And then again, you're not doing so much heavy work. You're just pushing like that. Okay? All right, anything else?
Sorry, same question, but for meniscal testing.
For if the patient's big? So again, I'll palpate the joint line. It's harder to feel in an obese patient. And again, I'm lucky that I get reps every day, right? So you guys aren't seeing it every single patient, but that's all I do. But yeah, again, I think flexing the knee helps, letting them support it on the table. Sometimes even if you want to sit up at the side for a really obese person, just let their legs sit like that. And you can find their joint line that way. You just feel, again, the inferior pole of the patella is your friend. So put your thumb right to the inferior pole and slide off to the side, and that's where you'll be. But it is harder. There's no doubt. It's hard to palpate their parts. So she's nice. She's obviously very thin, and you can see her muscles in her outline of her bones. But on obese patients, it's challenging. So, okay. Yes? I don't really do I mean, I know. I don't do the Appleys very much. I know. I'm like, I don't even do that one. It's always funny when we get calls from insurance companies and they're like, you haven't done this test. And I'm like, I don't even do that one. I'm not sure.
Dr.
Yes.
Edwards, there's another question. Oh, yeah. Hi.
Yeah, hi.
There's a question from the
from the chat?
app.
Okay.
Yeah,
Yeah.
on the chat. So what are your strategies for ligament exam testing in acute knee injury with acute effusion and a lot of pain or the patient's guarding?
Well, the best time to test them is right on the field when it happens. And most of us aren't there. But if you happen to be on the field before they get that big effusion, that's when you get the best exam. And they haven't tensed up their muscles yet either. But then your suspicion has to be very high, because then you see an offensive lineman a week later in the clinic or a few days after, they've got a huge effusion, and all their testing will actually be negative other than the effusion. So you try, their muscles are so strong, they're in spasm, that their Lockman, interdrawer, everything will kind of feel normal. So that's a patient, but just based on their history and the fact they have a large effusion and what happened, that you're going to order an MRI on anyway, even though those tests will feel normal, because that's a problem, because those often get missed if you're just relying on the Lockman test. So that's one thing to be aware of. So if someone comes in your office and they've got I heard a pop, I was playing soccer, and now I can't, I can walk on my knee. That's the other thing about ACLs too. They'll get that first effusion, it's miserable. And then once that effusion goes down, they're actually pretty functional. So a lot of them get missed. And it takes so long to get in to see all of us, right? So if you're not seeing someone within that first week, 3 or 4 weeks later, they might be cruising around and feeling pretty good and like, hey, I'm able to run again. I feel great, but their ACL's torn. So just something to think about, because they don't always. So oftentimes you're just basing it on that history. Okay, the history for that patient is really important. Yes?
Do you ever recommend like arthrocentesis to pull the effusion away and put a little lidocaine in so you can get an unobstructed exam?
You can do that. I think it's fine to do that. I usually don't, just because I'm always worried about introducing infection into the joint. So unless I know exactly what's going on, I don't like to stick needles in and pull fluid out. But a lot of people do. So I don't know, Carlin, do you do an arthrocentesis right away or wait?
I guess, it would depend on my practice setting, I think. I think if I weren't able to get advanced imaging, and, maybe I would do that to try to increase the sensitivity and specificity of my exam.
Yeah. I mean, I think you can. I think we're lucky, right, that we can just get an MRI kind of pretty quickly. So I tend to not like to do that in an acute setting. I'm always worried about introducing infection. Then there's a patient who would come in, maybe you're worried that they have a septic knee, and that's a different patient. Then I will be pulling fluid off if my suspicion is high for that. But if they've had a trauma, they've got some acute swelling, I'm not usually sticking a needle in it. Because I'm thinking about surgery. I'm like, I don't want to put a needle in if I'm going to operate on them, so. Okay, yes?
Do you ever do the duck walk thing?
Yeah, I do. I like the duck walk exam. So sometimes I'll have them, and you want to show, I was going to get down. But yeah, they can get down and that can reproduce pain and have them walk like that. So pain in a deep squat is also indicative of a meniscus tear. So that's a common thing they'll complain about. I do like the duck walk. Okay. Yeah, sure.
Does injection of a steroid delay surgery?
It does now. So in the past, that answer would have been no. And now there's a thought, not a thought, it's research shows if we operate and they've had a steroid shot within 3 months of the surgery, that the risk of infection with the surgery is higher. And in rotator cuff tears, the risk of failure of that rotator cuff is higher if you operate in that 3 months. So we really want there to be a clean slate before we go into surgery, and try not to have a steroid shot within that 3-month window before. And there's also research showing ACL tears, if you wait over 3 months to operate, they have a much higher rate of having more damage in their knee. So we used to not really know, well, you could probably wait a year or do it in 6 months when you're out of school or whatever, but now we know we like to get to them within that 3-month window, because they get more chondral damage, more meniscal tears if you go over 3 months. Okay. If we operate on them too fast, they'll get very stiff. So that's the other problem too. We don't want to do it that first week. We usually send them to the physical therapist to do prehab, get their range of motion back, get their swelling down, and then they're good candidates for surgery. But if we do it too quickly, then the surgery, they used to do them at ski resorts all the time. Patients would rupture their knee at Vail and go have their ACL done, and they would get very, very stiff because it was too fast. So, yes?
I had a question about the McMurray test.
Yes.
I couldn't tell, maybe I missed it. Are you feeling for clicking or are you causing pain?
Both. You can feel for the clicking, and then I also, if that reproduces pain, then the class of McMurray though is you feel for the click, right? But the pain is also indicative. I call that a positive McMurray's if they feel it. Okay. Yeah.
Do you guys do any surgeries right away where you don't use other tissue? Because I've worked on some patients in Switzerland where they did the surgery right away.
For ACL?
ACL tear, meniscal tear, and MCL. And they didn't use any medical tissue, they just used their own tissue.
So if it's a knee dislocation where they've ruptured every ligament, then we do try to get to them very quickly. All right, so that is one reason that we might go quickly on it. And there's evidence to show if you get to them under 3 weeks, they have a better outcome than if you wait. So, but that's for multiligamentous injuries, not just an isolated ACL.
Within 3 days.
Yeah. Sometimes too, if they've got a meniscus tear that's maybe locked or flipped, then that's a reason we go to them quickly too. Okay, so once in a while you'll see us kind of cheat on that, because if the meniscus tear is flipped and incarcerated in the joint, then all the rehab in the world, they're not going to get their motion back, and you'll tear up that meniscus if you keep rehabbing it. So we'll fix them right away. So it might have been something like that. We do try to get to the meniscal tears quickly, so because we have more of a chance of being able to fix it and keeping it.
Along those lines, I wonder, Dr. Edwards, if you could talk a little bit about meniscus tears and degenerative tears versus tears where, you'd rather see the patient sooner than later for a referral. So what kinds of meniscus tears, if we see an MRI report with a meniscus tear, what are some key words to look out for where, hey, this patient actually, might benefit from seeing a surgeon?
Yeah, definitely that bucket handle meniscus tear, or if they have a locked knee. If any of you see that, that's something we want to see within a week, and we'll usually take them to surgery that week. So that's probably maybe what you saw in Switzerland, but that's one that we're concerned about and want to get to right away if they've got that locked tear or a bucket handle tear. If it's a degenerative tear, age-related, horizontal component, you'll see complex meniscus tear on their MRI. Those are one, and particularly older patients too. I think if you've got a 15-year-old who comes into your clinic and they've got a meniscus tear, we'd like to see them fast. We don't want them to wait so long. If you've got a 68-year-old who comes in with a meniscus tear, that one's fine to wait, and they can do rehab. We would encourage them to do rehab and maybe try an injection before we operate on them. And again, that's evolved since I've been in practice, because we used to just fix everybody right away. Now, there was a good study out of England and out of the VA, I think it was the New England Journal of Medicine, that was published, 15 years ago, showing there was somewhat of a placebo effect on patients, particularly older patients with arthritis that were having all these meniscal surgeries, that they all got better, whether you did surgery or not. So now we definitely try to not do surgery if we can. Sometimes they still need it. Yes?
As you can tell, I did my training a long time.
Me too.
My understanding is that when we were first, they didn't repair meniscus tears, they just took them out.
That's right. Yeah, we used to take them all out.
So there was surgery that you can sew them together?
Yes. Yeah, we sew them together. And it's become easier and easier. We used to have to open the knee to sew them together and make open incisions. And now we have these wonderful little devices that make it so easy for us to fix it. It actually takes me less time to repair it than to trim them out. So, and again, in a younger, healthy patient, it's better for them to maintain that meniscus tissue and have their shock absorber work than not have one. So yes, we fix a lot of them now. And the rehab's totally different. So that's the problem, is that the ones we would trim out, they could get back to activity right away. And the ones we repair have a much longer recovery. So today I did a woman, 34, she's got a 4-month-old at home. She had a big flip meniscus. She's like, please just trim it out. She goes, I don't want it fixed. And luckily it was one, I didn't have any moral injury trimming it out because it wasn't fixable anyway. But when I compared the two rehabs to her, she's like, I can't do crutches right. She has a newborn at home. So she felt like, please trim it out. I've got to get moving. And she was a trimmer anyway, so, yes.
I'd like to piggyback on the question about the meniscus repair versus not repairing it. It seemed that the thinking or the researchers say blood supply is one of the issues there. So is that now not what you would tell someone?
No, it's still the blood supply. That's true. So there's different zones of the meniscus tissue, and the peripheral zone is what we call red zone, where it's got a decent blood flow compared to the more central part. So that's a big part of my decision making. Is this in the vascular zone or not? If we do a meniscal repair in the avascular zone, it's not as likely to heal. And sometimes, 6 months later, they're back on the table needing a trim. That being said, we're now fixing some of those that we used to say, oh no, that's not good enough. So if they're younger and they have a tear that's avascular, we are starting to fix some of them where 15 years ago, I wouldn't have done that, but now we are, and we're doing microfracture, different things to allow their blood flow into the knee. Yes.
How much can the MRI tell you what vascular, as opposed to when you're in arthroscopy and you're there as you're
Good question. Yeah, MRI, it's gotten so much better. Now with the 3 Tesla machines, even 6 Tesla, it's often going in there, but we don't know for sure until you're looking. I mean, the gold standard is really probing it and looking at it. And sometimes even the span between the MRI and when we get to surgery, it's changed from there. But the MRIs are shockingly accurate. And we have really good radiologists in San Francisco that are like, I see a tear at the 10 o'clock position that's a radial split. Like, they will describe it so clearly to us. And then you go in there and it's exactly what they're saying. So it's like looking at a high-def TV versus an old black and white TV, what we had 20 years ago.
Just one last question.
Sure.
Age where you would actually would care?
That is a controversial question, I would say, in our department. I really talk to the patient about what their options are, but I do think the recovery is much harder in older people. Older being like over 60, 65, even 50. I mean, if it were my knee, I'm 50, I would probably have it trimmed at this point, because I would need to get to work quickly, and I wouldn't want to go through the whole rehab. But there are other surgeons in our department that would be more aggressive in fixing patients. And I have one partner who is speaking, I think, tomorrow, and he fixes people into their 70s routinely and has great results. And a lot of people are interested in his work because at first people were like, oh, this is pretty aggressive, but the patients are doing pretty well, so he's got good results doing that. So. But they're in for a much longer recovery. Yeah.
I'll take one more question.
Yeah. Yes.
Just to go back to the patellofemoral stuff. If somebody comes in, they've started running, and they're just 20s, 30s,
yeah.
They get the pain. Do you kind of say, okay, you need PT, and then you're going to have to maintain this, just exposed, you kind of have a biomechanical weakness, sorry? Or would you ever suggest that someone kind of learns how to run differently?
I think all those are appropriate, yeah. So I want them to keep running. I think that's, if they are passionate about that or they've just started, oftentimes in that patient, maybe they've just started, they might need to start a little bit slower. And we actually have a human performance center at UCSF where they can analyze their running, they can do all these things. They can look at their foot position as they plant that can kind of help determine what's going on. And they do a biomechanical analysis of their running. So that's an option if you have a patient who's frustrated and not getting better. There's some of the shoe stores, they can go for a shoe fit analysis and make sure they're wearing the right shoe. I often tell them, though, they need to kind of step back a little bit. I want them to keep running because I think a lot of patients still get told you should never run again. I hate that. Why would you ever tell someone? If they want to do it, let them do it. But they've got to maybe do it smarter, start slower, maybe run on a different surface. Maybe they start on concrete and they need to start on a track or grass, something softer. But I try to figure out a way they can stay active. So.
All right, so it's time for our break. I think Dr. Edwards can probably stay up front for a few more questions if people have them, and we'll reconvene here at 5:30. Thanks, everybody.